So I know one time we took the car over on the ferry and we ended up in the port, what everybody calls Port Jeff. And there was a pizza place that was brand new called the Coliseum or the Colossal Pizza. Do you know this?
So in Port Jeff Station, there's a rivalry between those who believe that Coliseum pizza is the best and those who believe Carnival is the best. And I'm in the Carnival camp and go back to Carnival every time I'm home.
Okay, so then that rules out the possibility that we were in the same pizza place at the same time in the summer of 1980, since you went to the rival shop and I was at.
Yeah, I would never have been there at Coliseum. Sorry.
That's too bad, because it would have been really funny if we had crossed paths many, many years ago. So, anyhow. Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast features stories and wisdom from some of the best CMOs in healthcare. These leaders face some of the toughest challenges in healthcare right now, and they will share with you their insights about how they do that. Today, our guest is Dr. Doug Salvador, the former Chief Medical Officer at BayState Medical Center in Springfield, Massachusetts. He grew up in Port Jefferson Station, Long Island, New York, and is a very proud graduate of CMOs Senior High School, class of '89. After high school, Doug went to Johns Hopkins University, where he earned his undergraduate degree in biomedical engineering, and he stayed at Johns Hopkins, where he earned his undergraduate degree in biomedical engineering. He stayed at Johns Hopkins and earned his medical degree there before going to the great University of Rochester Medical Center for his internship and residency in internal medicine. He later went to the Beth Israel Deaconess to complete a fellowship in infectious disease. And finally, he has also earned a master's in public health at Harvard's Chan School of Public Health. Doug, welcome to the show.
Thank you, Lee. It's a pleasure to be here with you.
It is indeed a pleasure to have you. And there's one thing we have to get into before we get too far into the show. And that is, I know you graduated from high school on Long Island, but I failed to ask if you were also born and raised on the island.
That's right.
So I failed to tell you this the last time we talked. I was born in New Haven, Connecticut, across the Long Island Sound, and lived in the Milford and Orange areas until I was about 9 when we moved to Ohio. And one summer I returned to Connecticut to stay with my cousins so that I could stay with them on their boat and learn about fishing and boating and that sort of thing. And at one time, I seem to have a memory that there was a ferry between Bridgeport and Port Jefferson. Does that ring true?
You bet. I've taken that ferry many, many times. It's gotten me from New England back home and vice versa.
Oh, perfect. Because I wasn't sure if this was some story in my head. So it's great to know that there's some validity to this, because the rest of the story wouldn't make sense. So I know one time we took the car over on the ferry and we ended up in the port, what everybody calls Port Jeff. And there was a pizza place that was brand new called the Coliseum or the Colossal Pizza. Do you know this?
So in Port Jeff Station, there's a rivalry between those who believe that Coliseum pizza is the best and those who believe Carnival is the best. And I'm in the Carnival camp and go back to Carnival every time I'm home.
Okay, so then that rules out the possibility that we were in the same pizza place at the same time in the summer of 1980, since you went to the rival shop and I was at.
Yeah, I would never have been there at Coliseum. Sorry.
That's too bad, because it would have been really funny if we had crossed paths many, many years ago. So anyhow, let's find out a little bit about how you traveled from Long Island and CMOs Senior High School and arrived through all of the training to the role of the Chief Medical Officer. What are you doing now? Tell us about your story.
Yeah, so I'm going to start backwards quite a bit in time. I'm a first-generation American. My dad came over in the 1960s as a young man from Portugal, and my mom from Colombia in South America. They met on Long Island, and they raised me and my sister there. Mom stayed at home, and Dad was a concrete construction worker, and I did a lot of concrete construction work with him growing up, and I think that in a lot of ways has shaped who I am and how I did the job as a CMO, and how I make decisions. So I ended up not having a lot of professional role models, physician role models, and so I went to the guidance office there at Comstock High School and took the career aptitude test, and it spit out biomedical engineering, which I'd never heard of. But I looked into it and decided, as a math and science kid, that was a good idea. And I wasn't good enough to play Division I basketball, so I ended up at Johns Hopkins. I stayed, as you mentioned, for medical school, and at the hospital there, the best diagnosticians were the infectious disease docs. So when physicians didn't know what was going on with their patients, they'd call infectious disease and they'd come figure it out. And that's really who I wanted to be when I grew up, being in that environment. And similarly, really exciting time in infectious diseases because the protease inhibitors had just come on the market. We were watching people who had death sentences literally rise from the grave before our eyes. So I knew I was really interested in infectious disease and HIV. And when it came time to do the fellowship and kind of choose my path from there, I was on an HIV clinical trials pathway. But along the way, I looked up and thought, I could enroll patients in an ACTG trial for 3 years. We could send the data down to St. Louis or somewhere and have someone else analyze it and hope that we publish a paper that would make a huge difference in thousands of people's lives. And I was just a little uncomfortable with the delayed gratification. So when I did my MPH during the fellowship, I took the course in quality and patient safety, and the light bulb went off. I could use the scientific method. We could ask questions, create hypotheses, collect data, answer those questions, but we were going to make care better tomorrow and next week, not in 4 years down the road. So that really started me on the path. I took my first VP quality and safety job 2 years out of fellowship. I had been doing some clinical work, but also some infection control and some quality improvement, and really just a couple of years of that solidified that this is really where I wanted to go. And I spent 20 years doing physician leadership of quality and safety in hospitals and health systems, and really being enamored with patient safety, creating cultures of safety, creating psychological safety on clinical teams, and also the diagnostic process. How do we get the diagnosis right the first time? How do we get it right more often? Really became an area of focus for me in my work as a CQO and a CMO. So after 20 years in hospitals and health systems, I had been for a couple of years, like many, after the pandemic, taking stock and asking, what do I really want to do? And I went through a process of networking and some writing and getting some help with that. And I really came back to what I love is patient safety and diagnosis. And so I'll be working as the chief medical officer for a consulting firm that does federal contracting in the patient safety, diagnosis, and patient engagement space. ATW Health Solutions out of Chicago is a small but growing quality and safety firm that has some interesting contracts with HRQ and HRSA and the CDC that are the kinds of things I'd really like to work on. And in addition, give me the opportunity after 20 years in kind of the same space to get back on a learning curve and learn the federal space and see how I can make a difference from this part of the health system.
That's a tremendous journey, and there's not anybody who would argue that there's a shortage of skilled physician leaders in that federal space and continuing to bridge the gap between administrative, non-clinical folks, the payer side, the federal side, all the way down to what it means for individual patients and groups of patients. You said something that I would like you to expand on a little bit. As your clinical years unfolded and you began to really find yourself magnetized towards patient safety, you made a comment about creating psychological safety for the team, the people that you worked with. Was that something that you prepared for or learned as on the job training? This notion of psychological safety is not commonly spoken about in our medical training. So I'm curious where you picked that up.
Yeah, it was really in my work as a chief quality officer, patient safety officer, right? I took the IHI's patient safety executive training course. I later taught in it for 8 years. And I taught alongside Alan Frankel and Michael Leonard, and taught the culture of safety day for that cohort of future patient safety officers. It was always something, an idea that made sense to me from my experience in training, and then I read everything I could get my hands on that Amy Edmondson ever wrote.
As you continue that deliberate growth mindset of learning to perform well, both in the quality role and your clinical role, and ultimately, again, thinking forward to today, what do you really want to be doing with your time? In addition to your master's and the IHI, and I didn't know you were a teacher, which is fabulous because I've gotten into the teaching work too. What else have you done to prepare for these higher level roles as things unfolded? Can you speak to any other diligent preparations?
Yeah, so I think I can remember graduating from the MPH and saying, "Man, I've had enough school. I don't know that I'm ever going to go to school again." And I got this first job as a VP of Quality and Safety because I had the MPH, I had the epidemiology degree, I had stories of using data to improve care, right? But that and it was a time where, it was long enough ago that there were not a lot of patient safety officers who were physicians. There were not a lot of, chief quality officer roles. And certainly there was not this proliferation of quality officer for the Department of Surgery, quality officer for the Department of Pediatrics. So that training pathway that exists today, where you might go get a master's or a PhD in patient safety or these
Right.
other degrees, it was learn on the job. IHI was certainly a source. But I read every, once I got the job, I realized success was all about change leadership, change management, and organizational development. And so I read every book I could get my hands on. I hung around with the organizational development folks in our HR departments and tried to collaborate and do work with them. They were great partners in the culture of safety work. And the teaching, I think, as you mentioned, helps. So, I was able to achieve the rank of professor of medicine at the UMass Chen School of Medicine before leaving the last role I had. I'm still in that role. So, in previous to that, I was the course director for a first-year medical school course in quality and patient safety. I ran some national courses, as well as being kind of a founding faculty for a physician leadership fellowship at a health system, and teaching in that and doing the course design work for 6 or 7 years. And I've always done a lot of teaching as part of the work as a CMO. I've always felt like when we do this quality work, it's, we're trying to shift culture. We're trying to change the way people approach medicine, and we're not doing our jobs if we're not working on that next generation. So as you know, when you do that teaching work, you learn more yourself than you impart. So I didn't have a lot of other formal areas. I would say I've always been very interested in maintaining peer-to-peer networks and relationships, and I've always had 3 to 4 people that I respect a lot, who I typically have a monthly phone call with and check in. And I can honestly say over 10 to 15 years, I've learned so much from staying in touch with peers, and having that network of close people I could rely on and reach out to.
Is there anyone in that group that you, and you don't have to, want to mention by name, and more importantly, some of the characteristics or attributes that you have absorbed into your character and being?
Yeah, so there are many, right? I'll just name a few. So the first that comes to mind from earlier in my career is a guy named Jeff Brown. He's a cognitive engineer. Has worked in the FAA. He's done interesting work within the correctional facilities, creating cultures of safety. He's done research in patient safety in cath labs and in hospitals and EDs. And he's currently kind of leading a primary care research center up in Maine, which is where he's from. Just a brilliant patient safety mind, and he I think would value the practical stories that I would run by him, and I would certainly value the lessons and the questions he would ask, and his perspective on them. So just a really smart guy, a patient guy, a great listener, but someone who really loved to engage in that back and forth, and to share information, and was always trying to learn from me as much as I was trying to learn from him. So those are some of the characteristics, I would say. A second one who I did this with for a long time, and still remain in touch with, is a guy named Steppy Mehta I worked with in Maine for a while, who went out to Arkansas to become the chief clinical officer at UAMS in Little Rock, and then eventually the CEO, and led that organization through the pandemic as its CEO. And he and I did some quality improvement work together. But his global perspective, his systems thinking, and his incredible kind of commitment to his values were things that were particularly valuable in our conversation. So he's a guy who did work in the Leadership Institute, Leadership Alliance at the IHI, specifically on healthcare as a human right. And I always got a lot out of our conversation. We really, they ranged, from spending an entire call hearing about his family and his daughter's music and their travels, to digging into issues we were each having in our organizations.
We in our executive academy, we talk a lot about values because they become foundational and cornerstones to navigating when things get really challenging. And it always helps to identify your values and go back to them, right or wrong, but never in doubt about your values ever. And you also made a comment about talking with people on a regular basis as a sounding board, to share ideas and to get feedback and input. And we're going to go in two directions with this. So this is an idea that took more formal shape in the 80s under President Reagan. So it's not new, and many people know about this, but to have a personal board of advisors, if you will, and they are not necessarily physicians, they are not necessarily physician executives, although some may be, but they come from a range of activities and backgrounds. You kind of allude to that. So would you say you have a very personal board that you can communicate with?
I do, yeah. And I've been blessed by having mentors that are willing to spend time, right? So one of my heroes in patient safety is Gordy Schiff, who's was in Chicago for so long at the Stroger. And he's now at the Brigham, which isn't too far from where I am. And he's a guy who I spoke with a week and a half ago, who I can pick up the phone or email anytime, who is always there to help. And I think we need folks like that, and we need to be those folks for other people, right? So from the time I 10, 11 years ago joined BayState, I had 2 to 3 to 4 mid-career professionals. Some were nurses and nurse leaders in operations. Some were there was at least one pharmacist, some were physicians who asked me to mentor them. And I would carry a load of 2 to 4 mentees at any one time during those 11 years. And I thought it was very important to do it formally, to distinguish what are we doing that's coaching around a specific topic area that maybe I know about, systems thinking, quality, patient safety topic, and what's really mentorship. And if this is all about mentorship, how are we going to sort of assess what you want to get out of it? How are we going to interact? Typically, I would try and formalize it in a way that we're spending time once a month, but you have access to me 24/7 in between those months. And that's where the most monthly meetings, that's where the most valuable interactions are going to happen, because you just had a bad encounter with somebody and you need to debrief it, or you're about to have a really important meeting you're nervous about and you want to go over and prep with someone who's not in it with you. And so I currently have 2 of those relationships that mentees that I'm working with, but I think we need those folks for us, and we need to be those folks for other people. And included in that, I would say there was one person who was also an executive who approached me and said, "Would you like to do a peer-to-peer mentorship?" And we had a monthly meeting. So a guy I actually spoke to on the phone yesterday, who's retired now, but we did that. So I think those networks are crucial to being able to do the job.
Totally agree. And it's a combination of having that personal board of advisors, having mentors who have your best interest in mind. That's the role of the mentor. The coach, that's like on the baseball diamond. They're teaching you how to hit that ball to the left field, to the right field, and down to the ground. Again and again and again, coaching is perfecting those skills. And then you have a wide range of other people, and to pay it forward like you do only increases your competency and capability. So wholeheartedly agree, and always want our listeners who are thinking about physician executive careers that these are not in the textbooks, right? These comments about surrounding yourself with different kinds of people to offer you different skill sets and sounding boards, crucial. What do you think your coworkers in at any point in your career would say if I could interview them about Dr. Salvador? What would they speak to? What would stand out? What do you think they would say?
So, as I'm sure you know and experienced, I know a lot of it because experienced a lot of 360 evaluations where I've been given that feedback directly. But I do think people would say that I'm a systems thinker. I think people appreciate that about me. And then one thing that I've tried to cultivate, and I think is actually pretty important to the CMO job, and I feel good about hearing from other folks, is that I was someone who they could come to with difficult problems. I was someone who, when they were having trouble with coworkers, when they were feeling like there was something they couldn't bring up to their boss, they could come to me. And I think the CMO role, at its best, has someone who's like that in it. I can recall having someone I never met before walk out of the OR, upset by an interaction, and come knock on my door because someone told them they could trust me and they could come to my office. And I think that that's pretty important, that you build that trust within the organization, that people can come to you. And I do think lots of folks would say that about me.
That is one of the highest forms of compliment, that someone would speak about you when you're not there. So that this would be a kind of a sponsor. Hey, Dr. Salvador is who you need to talk to. You can trust him. Don't know how this is going to turn out, but go have that conversation. That is a very, very high compliment. Hats off to you for that. We're gonna talk a little bit more about some of the tough stuff that goes on for chief medical officers, and in particular, aside from COVID-19. And you and I entered medicine, as you described, when HIV was an enormous challenge. But if we put those two things aside, what was the hardest thing that you personally faced in your role as chief medical officer or chief quality officer, aside from those two things?
So I I think I'd like to answer this a little bit generally. So, some of your listeners may know the name of Jim Conway, who's a legendary COO at Dana-Farber Cancer Institute, executive at the Institute for Healthcare Improvement, now deceased, and a driver of patient engagement, patient-centeredness in institutions. Another hero of mine growing up, and I was training in Boston, and when I went to go leave Boston and take my first job as a VP of Quality and Safety, he gave me one piece of advice and something to do. But the advice was the hardest thing I had to do as a COO was put on the parking lot something that I knew would hurt or kill a patient. But we can't fix 20 things in a year, and if we try to, we won't fix any of them. And I never forgot those words in the 20 years I spent doing the job, and I think he was exactly right. So I think that trying to make the best decisions about, can we work on 3 things, can we work on 5 things, how do we create sustainable solutions in the patient safety and the quality space, and understanding that if we react to everything that happens and try to solve everything, we're not going to build those sustainable solutions, and keep the faith when things go wrong and patients are harmed. That to me is one of the hardest balancing acts as the CMO or the CQO.
Yeah, absolutely. Competing priorities. We talk about that in our executive class. We talk about strategic thinking and system thinking, because you can apply some of the work at that systems level to try to reduce the constant reactivity, so that then you are positioned to deal with the right priority at the right time. And it does not come easy. As clinicians, we are trained to triage the next admission, the next procedure, who's on our census that we have to see first when we're rounding or teaching. But it is very different at a more administrative level, all the things that are coming at you, how to regulate and self-regulate. Because like you said, if you try to fix everything, you're going to fix nothing. Totally agree. So let's talk about perhaps any specific event that might have been one of the biggest fires that you had to fight, and hopefully you were able to put out, and any tools that you used, leadership tools, to fight that fire.
Yeah, so the dramatic ones are the ones you remember in that regard, and the complex ones as well. So I in the health system I was working at, there had been a hospital that was acquired into the system, and a year and a half later, it was discovered that there had been a breach of cleaning protocol in the endoscopy unit. And that turned into, and because of my background as an infectious disease doc, a hospital epidemiologist, that the leadership responsibility fell to me. There was communication with the Board of Trustees, who was nervous. And it became a monthly meeting standing agenda item where I stood up in front of them and gave the reports. There was taking the media calls from the newspaper and the television reporters. The lawyers were circling and trying to put together class actions, and our internal huddle teams trying to understand, how did we acknowledge and take responsibility for the breaches that occurred, and communicate with our community, who was really nervous about getting care there going forward. And then one of the interesting things was the regulatory scrutiny. So the Department of Public Health and others came down, got very invasive, running by what really was the risk population, who and how and what do we say in our notifications to individual patients who'd received care, and then what we had to do in response. And I can recall that got pretty contentious at times. I was pretty adamant that they were characterizing the risk, that there were risks that really were not um, substantial that they really wanted to be disclosed and talked about and tested for. And so I think in retrospect, I probably pushed back too hard and they punished us for it. But there was a whole lot that went into that crisis, and it does stand out in my mind.
Yeah, that's tough. That I can feel the difficulty in your description of what you went through, and many of us who've been in these roles have had similar, very difficult experiences. Aside from COVID and facing the public, but what is unique, I think, in my own opinion, from a physician executive standpoint, is that we are trained very early in that late second year and certainly through our third and fourth year of medical school how to communicate effectively. And hopefully we have great teachers that teach us that, and to share very difficult news, bad news, the worst case news. And sometimes they come across as mistake like news, like, I'm sorry that this happened to you, but this is what happened. And you become skilled at telling the truth in an honest and compassionate way, but your audience is not always prepared for your bluntness or your transparency. And I personally am always stunned to watch a chief medical officer at a press conference and the way they talk to the camera versus our administrative non-clinical partners is different. And I'm convinced it's because of our training that we have a different way of communicating some very awful things and deal with reality. What do you think?
Um, Breaking bad news to patients, being as a clinician, being in that position of understanding that you're dealing with family and individual situations with your patients that are often, as they say, the worst times of their lives, um, gives clinicians in particular experience and training and understanding about how to communicate compassionately and honestly with people in general. Yeah, I agree.
Okay, good. I want to make sure we've established that. What do you think has been the hardest aspect for you as a person, as a human being, of the job and the role and the titles that you have carried?
So I think that my recent experience, I've spent 2.5 months doing not much work after 20 straight years of kind of being in that executive role. Um, Something I anticipated, but really after having that time off, didn't understand fully was carrying the weight of the patient harms, the physician staff harms that come with the delivery of healthcare, feeling responsible for the care of all the patients in the health system. And that really was a heavy burden. That is a heavy burden for people in these roles. And that's oftentimes the hardest for me that I do, at difficult times where there are errors that cause harm. I do lose sleep. I have lost sleep in my career. I do think about them. I do feel responsible for building the systems for safe care that also protect our nurses and doctors, and when they're harmed as well. It's a difficult burden.
We're in a small club, Doug. There are not a lot of chief medical officers, despite the plethora of institutions in our U.S. healthcare, and it at times it can be bone crushing. It literally can be bone crushing. The weight that we carry and the burden, and we're good as physicians of beating ourselves up to pieces. And I'm not in any position to tell anybody not to do it because I think we default to it. Now it can create some harm and some self-harm, and we as leaders have to look for folks that are in trouble. But it is definitely a mountain of responsibility, and it's good to have people that you can talk to, as we talked about earlier in the show, to be able to vent, share, discuss, and move through those experiences. And you carry them with you your entire life. You never get rid of them. So with that, what might you say to your younger self, 15, 20, 25, maybe even the kid in the pizza shop? What would you say to your younger self about what it's like to become a physician executive.
So, you know, that feels a little bit to me like a regrets question. Honestly, I'm not a regrets kind of person. I think we all need to muddle through best we can. I look back and I mostly think my intentions were good. I knew what I knew, and I made the best decision I could at that point in my career. But there are a few things looking back that I guess I would say related to the conversation we we're just having. It's okay to commit yourself to the role and the organization. And in fact, I'm not sure you can be successful if you don't.
Agreed.
So you have to take that burden on, right? I would say deliver value to the organization, to your patients, the community, the doctors, and the team members every day. If you do that, you can leave the organization at any time with a clear conscience, knowing you did your best. You don't owe the organization anything. Organization doesn't owe you anything. And that's how I feel like I left both of the organizations I was in. And it was something I thought about a lot. Am I pulling my weight? Am I delivering value? They're paying me a lot of money. Am I worth it? And if not, what do I need to do to make sure I'm delivering the value in this community, in this organization? I'd also say, don't forget that your family and the people closest to you are the most important thing. I did things like when I switched jobs middle of my career, I set up my calendar so I had one morning a week where I started at 9. And that was non-negotiable. The morning would change, but I had at least one morning where I started at 9. That meant I could make breakfast for my kids. I could take them to the bus or drive them to school. And that time was precious, and I guarded it. And I think, it's easy to get swallowed up in the job, and you need to remember that your family's most important. One thing that really helped me in my career was in my first stop in this executive role, a few years in, I got frustrated. Things weren't working out the way I wanted them to. And I was asking myself, is it me or is it the organization? Are they taking advantage of me? Am I saying yes and putting myself in the wrong position? And I was smart enough to ask that question and then go seek help. And I started to work with an executive coach who I still work with. So it's 15, 16 years later. I during that time often told people I couldn't imagine doing this job without an executive coach. And for most of those 15, 16 years, we met every 2 weeks. And we constantly had a list of things I was getting better. We constantly did 360s and got more feedback. And I always had a list of leadership competencies, things I was working on. And so I guess I'd tell that younger person to go get that executive coach sooner.
Yeah. So that was brilliant. And it was not a regret question. And I apologize if it came out that way. But what it is it is the CMO leadership pearls question, right? So you're making rounds, you're teaching your medical students, and you want to give them a pearl. Have a coach always and forever. Look in the mirror, ask yourself, is it me or is it them? Create value, right? You just listed pearls, and those were brilliant. So well done. In general, healthcare in the United States is considered by many, and more so lately than almost at any other time, on fire, like a total dumpster fire out there. And there's a lot of things to choose from. But right now, what do you think is the biggest fire that you're seeing in healthcare, and what can a physician executive, chief medical officer do about that, if anything at all?
So, for me, it's the misaligned financial model, corporatization, the financialization of medicine, and the result of that is the loss of trust in hospitals and doctors because the financial model doesn't support meeting the needs of patients and communities. That's the biggest fire. I can remember after the housing bubble burst in the mid-2000s, I told people around me that I was worried about a bubble in healthcare, that we're harming people, we're disrespecting them, we're not meeting the needs of patients and communities. And what I feared the most was that the public would react to us in the same way they did to those bankers who caused the housing bubble. And unfortunately, I think that's happening now. And so I'd say wait, that's also an opportunity, right? Um, I often described my role as the conscience of the health system, right? I felt the pressure to be perfect because I was preaching respect, open communication about errors, doing the right thing for the community. And I knew that put a target on my back because people were looking for me to be disrespectful or to choose convenience or expediency over doing the right thing. I would often tell my team, people are watching us. We need to be perfect, right? Um, I also had the benefit for most of my career for operating in an environment where I had a boss who supported maybe being a little unconventional, right? So I was able to tell my board this story. I would ask them, how many CAUTIs occur in the U.S. hospitals each year? And I guess, Lee, I'll ask you that question. How many CAUTIs do you think happen in U.S. hospitals in a year in this country?
How many CAUTIs? How many CAUTIs there are? How many CAUTIs there are in the United States? I haven't. I used to know, but I'm not even going to hazard a guess. I do not know.
All right. Well, Lee, I'm sorry you're not playing my game with me, but the answer I got from the board members was a million, 1.5 million, 3 million, right? Because all they'd heard about in quality and safety was CAUTIs and CLABSIs and, and falls. And I told them it was 20,000, right? And then I said, how many people do you think are harmed with either killed or permanently disabled from diagnostic errors that occur in just emergency departments in this country in a year? And they were shocked to find out that that number is almost 500,000.
Right.
And so we need chief medical officers who are skeptical about conventional wisdom and challenge that it has to be the way it is. Most chief medical officers have responsibility for quality, have the same mandate from their CEO and their board. Get us a Leapfrog A, get us 5 CMS stars. And the message I was able to tell the board was those measures are important, right? We've done some great work in the last 5 to 10 years reducing the number of CAUTIs and CLABSIs, but it's going to get really hard to go from 18 in a year to 14 in a year.
Yep.
And if we spend all our time on that, we're not going to be working on misstroke in the ED, which isn't on Leapfrog and isn't on the CMS stars today. And we have far more information about what's harming our patients within our health system. And we have to create a strategy that balances, understanding we can't fix 20 things at once, that balances those external measures of quality with what we know is harming the most patients. And I think we need CMOs who are skeptical about this tunnel vision that's out there and are willing and able to push back. And then we also need chief medical officers who aren't taken in by the glitz and glamour of private equity deals and the promise of short-term capitalization and investments, but then, realize that those might come with having to change a clinical model for the worse, or lay off more staff than feels right for care, or feels safe. And so this idea that I started with, which was I often describe my role as the conscience of the health system. We need CMOs to be that conscience, to challenge the status quo, to advocate for the right thing to do in the patients, and to not completely fall in line with financialization as the best thing. Because the reality is the current financial model in healthcare doesn't work. And we need truth tellers and people who see reality.
The insight that you are describing is off the charts on a couple of levels, and I want to react and reflect with you. So we've had guests on the show talk about the corporatization of medicine. I love the phrasing, the financialization of medicine. It's the first time I've heard it used in that frame. And
it's a New England Journal editorial I can send to you, but they distinguish between financialization and corporatization. It was in the last year, and it the two together, I think, are even worse than the corporatization.
Yeah, well, I mean, yeah, I would agree. And to be the clinical conscience of the organization, Actually, it should be in the job description. Of course, nobody will do that, but it should be. And most of us attempt that. And to be able to adequately describe that, if everything is a finance, if every effort that we make is about the finance, then we're really on the wrong road to deliver healthcare. And, there are people who get quite animated about no mission, no margin, no margin, no mission. And you can go back and forth on it. And it's this philosophical runaround. At the end of the day, it is only about patients. You and I, Doug, did not create the system that is broken. We didn't create the system that doesn't work, that the financialization models don't work. And we have to figure out how to take care of people in spite of that. That is what we do. And I tell you, I am going to have to borrow some of your phrases as I teach and talk with others as I go around. So thank you for that. So this is getting towards the end of the show, and I'll give you a chance to add a little bit more if something comes to mind. But I just want to remind our listeners that being a chief medical officer is no small task, and it takes intentional preparation, although much of it feels like a trial by fire. And it was my old boss that told me that it is just like a career in firefighting. You start by going to a firefighting school, and you train and you drill until one day you're ready to go out and fight that fire. You put on your uniform and you start out as a fireman, and maybe one day you find yourself being called squad leader or captain, and then perhaps the fire chief. My boss always told me you cannot be a fire chief without first becoming a firefighter. And I want to know if you agree with that or not.
You bet. And, when you ask me what would people say about me who were colleagues, they'd say that I was very interested in how processes actually work, that I spent time, I was a infectious disease consult attending for 5 or 6 weeks a year for the duration of those 20 years. I was in the CMO role, CQO role, VP patient safety and quality role. And it was, and I was known for, being out of my office on the front line, talking to folks and seeing how things actually worked. And I think that's essential if you're going to do the job well.
And perhaps you would be the closest to being a fire inspector. You're looking for where the faulty wires are, where the sparks are, where the solvents are, because at a system level, you don't ever want the fire to get started, right?
Yeah, I would sit with, when I was on service, I would meet with the team on the first day, and I would say, look, you're going to get a different experience with me as attending, because I'm not really that interested in the newest drug to treat this disease or molecular modality. What I'm much more interested in is how we could have prevented this infection from happening in the first place.
Well, thank you for being on the show. You have been part of our Fire Chief podcast, the only podcast dedicated to the CMO. For our listeners, if you want to learn more about what it is like to be a CMO, listen to the show. If you want to be on the show, email me at Lee Scheinbart or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the entire video of the show on YouTube. The show's website is thefirechief.podbean.com. I love talking with chief medical officers from all over the United States, so please feel free to connect with me. Leave your reviews and your feedback and your comments, and share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.